Hi guys, welcome to week 6. This week we'll be discussing urinary system drugs, GI drugs, and antibiotics or anti-infectives in chapter 17. So 15, 16, and 17. You have a little bit of extra time for this part of the module. Week 6 has already started, but it will continue into next week due to the holidays. Everything is due on January 3rd at 11 p.m. and that includes your forum, your Part 3 of your drug project, as well as your MindTap assignments, your homework, and your tests for chapters 15, 16, and 17. So, starting with urinary system drugs. When you hear of urinary system drugs, the most common ones you'll probably hear talked about are diuretics. Diuretics are used to help get out extra water out of the body, especially in cases where somebody has edema, which is swelling, or congestive heart failure, which literally means they're filling up with water. Their body is overloaded with fluid. There are 5 different classes, and those are the thiazide, loop diuretics, potassium-sparing diuretics, osmotic agents, and carbonic anhydrase inhibitors, which are actually discussed in another chapter. So we'll be covering the first 4 classes in this one. Thiazides and related diuretics. You can tell it's a thiazide because usually it actually has that in the name, such as hydrochlorothiazide. And they cause the increased excretion of water, sodium, chloride, and potassium. And again, they're used in cases of edema from heart failure or liver problems. They're also used in hypertension to try to get total body water down, which will therefore kind of reduce the pressure on all of our veins and arteries, as well as to prevent stone formation for those with hypercalcemia. So right off the bat, if we said we were getting rid of excess sodium, chloride, and potassium, one of the main things we'd be worried about would be hypokalemia as a side effect. And that is too low of a potassium level, and that can cause cardiac arrhythmias. And as well as hyponatremia, which is too low of a sodium level. And again, I think we're going to cover hypercalcemia as well. So other problems that you can have with diuretics, always hypotension. The less body water we have, the lower our blood pressure, and thus somebody can suffer from vertigo, dizziness, especially when they're going from a seated or laying to a standing position. In addition, thiazide diuretics can cause blood sugar levels and uric acid levels to go up. So now that we have all those side effects, we can talk about where we'd want to be careful using it. As patients that we'd want to be careful using thiazide diuretics are those that have diabetes, a history of gout, which is an increased uric acid level, severe renal disease, impaired liver function, and over time, for people who are on diuretics for a long period of time, we want to keep an eye on their sodium and potassium levels. In addition, anybody who has a sulfa allergy or sensitivity, we want to be careful using thiazide diuretics. Interactions can include NSAIDs, corticosteroids, lithium, any hypotensive agents, because they can, again, lead to too low of a blood pressure, and anti-diabetic agents, because it interferes with the blood sugar. Next step is loop diuretics, and those you're going to hear, they usually end in IDE, furosemide, bumetanide, and torsemide. They act on a part of the kidney to inhibit sodium and chloride reabsorption, again, getting rid of those sodium and chloride, and then leading to increased urine formation. Wherever sodium goes, water usually follows. So if we're getting rid of sodium, we're getting rid of water. So they also can, because potassium also follows sodium, we're getting rid of potassium. So just like our thiazide diuretics, we are at risk for hypokalemia, so we want to make sure that we're supplementing patients and keeping an eye on their levels. It's basically used for the same indications, edema associated with renal disease, heart disease, or liver disease, as well as hypertension. And under the uses of loop diuretics, also mentioned ascites caused by malignancy or cirrhosis, and those are the fluid-filled pouches that you might see in someone's torso area when they have liver disease or cancer. Side effects, same deal, fluid and electrolyte imbalances, so you want to be careful and make sure we're checking levels every now and then, especially when somebody first gets started on these medications, and definitely while they're in the hospital, because it's easy to do with blood draws every single day. Hypokalemia, as well as hypocalcemia, and hypotension, of course, as with any diuretic, and hyperglycemia and increased uric acid levels, very similar to the thiazide diuretics. So you can follow the precautions and contraindications as well as the interactions. It looks very similar to thiazides, but they do act in a different way. Okay, so potassium-sparing diuretics. These are diuretics that aren't going to kick potassium out of our body. So we don't have to supplement somebody with potassium in this case. Sometimes you'll see one balanced with the other. You'll see a potassium-sparing diuretic given with a non-potassium-sparing diuretic, and that way you don't have to worry about getting rid of too much potassium all at once. Some examples are spironolactone and triamterene, and they're usually used when potassium depletion could be dangerous to a patient. Potassium-sparing diuretics may also counteract increased glucose and uric acid levels associated with thiazide diuretic therapy, and spironolactone is usually the drug of choice in cirrhosis. And so our side effects for potassium-sparing diuretics, we go completely opposite. Hyperkalemia, which can lead to cardiac arrhythmias as well. Fatigue, lethargy, and weight loss. Still hypotension, and also gynecomastia, which is basically enlargement of the breast tissue in males, and that's one of the side effects associated with spironolactone. So we have to be careful in patients, as with any other diuretic, in patients with renal insufficiency. If we're giving them a drug that's asking them to get rid of excess water, the kidneys are responsible for creating urine, and if they can't keep up with the drug, we're kind of putting the kidneys into even more danger. Interactions may occur between ACE inhibitors, which are your lisinopril, fasinopril, anything ending in pril, and that's because those also increase potassium, so we want to be careful with that. In addition, angiotensin receptor blockers, which are your ARBs, salicylates, NSAIDs, any drug known to cause hyperkalemia. Osmotic agents, usually used to reduce intracranial or intraocular pressure, not so much for patients with edema due to renal, cardiac, or liver disease. You'll see these used a lot more often. Either, again, the intraocular pressure is for glaucoma. If we're reducing intracranial pressure, usually it's an inpatient setting. Side effects can include fluid and electrolyte imbalance, GI symptoms, as well as central nervous system symptoms, increased heart rate, hypertension, as well as hypotension, depending on how well somebody's responding to the medication. And we have to be careful in anybody with kidney or cardiovascular dysfunction. We want to evaluate that before we start giving people these medications. So there's a chart on on page 253 that gives you some common names of medications in each of these classes, as well as their doses. And you don't have to remember those, but the names are important to match up to the class of drug. So medications for gout usually include NSAIDs and colchicine, and they don't so much act on, NSAIDs particularly are more for pain and inflammation. Colchicine as well is to help with pain and inflammation. They're not so much to get rid of uric acid as much as they are to help with the symptoms of gout. So gout is a buildup of uric acid, which usually causes swelling in joints, especially the big toe. It can be extremely painful, and it can be acute or chronic. Somebody can have an acute flare-up where they get that swelling, or they're dealing with it chronically, which is where they can still have those acute flare-ups, but we try to prevent them and keep them on medication for the rest of their lives pretty much. So NSAIDs, such as ibuprofen and naproxen, as well as colchicine, are used to treat acute flare-ups, usually the swelling and inflammation and pain that goes along with gout. Uricosuric agents are where we start treating chronic gout or people who have more frequent attacks. And an example of that would be probenecid, and it blocks reabsorption and therefore gets rid of uric acid. They don't have any anti-inflammatory or analgesic effects, so they wouldn't be used for an acute attack. You may also hear probenecid being given with penicillin, and that's because it also prevents penicillin. It kind of keeps the level of penicillin in the body constant. It won't let it be excreted. I'll let you go over the side effects, contraindications, and precautions, because I do have to keep these videos under 15 minutes, unfortunately, due to YouTube laws. Our next chronic gout agent is going to be allopurinol, and again, this is something somebody would be on daily to prevent those flare-ups. Again, no analgesic or anti-inflammatory effects, just used to decrease uric acid levels. finally, bladder antispasmodics. Actually, I think we have a few more things to go over in this chapter. Overactive bladder is a condition that is usually involving somebody who has to pee often and somebody who cannot, people who can't hold it to go to the bathroom. So frequency is defined as having to urinate more than 8 times in 24 hours. Urgency is the sudden need to urinate. Antispasmodics are anticholinergic in action, which means they block parasympathetic nerve impulses, and are used to increase the holding capacity as well as decrease the urgency of the bladder. Examples are tolterodine and oxybutynin, and they have similar side effects, especially in adults. And we want to be careful with these in older adults because they cause bad enough side effects in regular adults, but in the elderly, those side effects are multiplied in amplitude. So, side effects include drying above the mouth, the eyes, any secretions are going to be dried right up. Drowsiness and dizziness is what we worry with in elderly because of falls. Urinary retention and constipation. So as much as we want them to be able to hold their bladder, they sometimes find that they can't even go once they've started taking these medications. Confusion, increased heart rate, nausea, vomiting, etc. So again, we're going to be careful in older adults. We're also going to be careful in anybody who has bladder or GI obstruction because we don't want to make that worse. In addition, generally we don't see these used too often in children. That's pretty much self-explanatory. So, cholinergics, the exact opposite. Anticholinergics dry up. Cholinergics cause everything to start flowing again. So, sweating, salivation, peeing more often. We would see these used in post-op patients who are having trouble creating urine, or in pregnant women postpartum after they've had their baby to help them go to the bathroom as well. And urinary analgesics is going to be the last thing I cover. The rest I'm going to leave up to you, and it's talking about BPH and phosphodiesterase inhibitors, which are used for erectile dysfunction. So urinary analgesics are actually something you'll come into contact with quite often. Anybody who has a UTI is usually having intense pressure and pain, especially in near their bladder. And urinary analgesics help relieve that pressure and pain, as well as make it easier for the person to go to the bathroom. Side effects include headache or vertigo and mild GI disturbances, but the most common is discoloration of all body fluids. Phenazopyridine turns the urine. Anything that has secretion, such as your eyes, your nose, or your mouth, turns it orange, which is actually pretty cool. It can discolor contact lenses as well as clothes if you're sweating. So that's a pretty cool medication that works really well, but has that scary side effect that gets a lot of people. Okay, so the rest is up to you in this chapter. I'm going to cover 16 and 17 in a separate lecture, which I will post. And let me know if you have any questions on those ones that we didn't cover.